Michael Barkham and Louis Castagnier. The webinar will be recorded. You just got the message. It's the 7th webinar of our webinar series on the 7th edition of the Berin and Garfield's Handbook of Psychotherapy and Behavior Change. And this webinar is jointly sponsored by 3 organizations. It's SPRs, the Society for Psychotherapy Research, SEPI, and APA Division 29, Society for the Advancements of Psychotherapy. And today's topic covers, again, a very highly central and modern topic of psychotherapy research. And I'm very glad that we have a nice audience again. And the topic is CBT first, second, and third waves. Where are we and where are we going? And we are very pleased and honored to have 2 highly respected experts here for this topic. They both also wrote the chapters in the handbook, Michelle Newman and Evan Forman. And again, I would like to mention that this 7th webinar, as well as all the other webinars, you can find afterwards on our YouTube channel, which is by now a really nice resource for teaching material and research material. So check it out later. And I would also like to highlight that we have our next webinar in the next year on February 21st on increasing scale, group, and internet therapies. So we will, of course, announce it. Mila will, of course, announce it early again in the next year. So today's webinar will be lasting about 75 minutes and we'll have like three segments. So 2 will be given by each presenter. And at the end, we will have time for discussions. So I don't want to say anything more. Michelle, please share your slides and start. Thank you.
Okay, so my part of the presentation is going to be on the first and the second waves. And in terms of some background, the first wave of CBT emerged around the 1950s and focused purely on behavioral therapy. And this was based on classical and operant conditioning theories, reinforcement and punishment, functional analyses, and observational learning. The second wave in the 1960s focused on purely cognitive therapy and was based on cognitive principles of learning. And then CT, cognitive therapy, slowly merged with behavior therapy to become cognitive behavioral therapy around the 1980s. And I'm going to talk about CBT for specific disorders, starting with depression. In terms of depression, CBT has historically been viewed as a first-line treatment. And overall, the effect sizes for acute phase CBT were superior to treatment as usual, placebo, and waitlist, with medium to large effect sizes. And about 40 to 50% of the people treated for depression show clinically significant reductions in the symptoms. Acute CBT effects also improve both social functioning and quality of life. There's no significant difference between CBT delivered to individuals compared to groups, telephone, or guided self-help. Increased symptom severity or continued severe symptoms post-treatment is rare. And CBT can also prevent the development of depression by 21 to 22%. In terms of CBT and pharmacotherapy for depression, a meta-analysis found that combined medication plus CBT was not significantly different from CBT alone, both at short and long-term follow-up. Overall, there's no consistent evidence that CBT plus pharmacotherapy is superior to either modality alone. And there are not enough studies comparing CBT plus pill placebo to CBT plus pharmacotherapy. Acute effects of CBT also tended not to differ from interpersonal, dynamic, or supportive psychotherapy and pharmacotherapy, although a lot of studies are underpowered to find small effect sizes. In terms of relapse prevention, discontinuation of CBT for depression is less likely to lead to relapse than discontinuation of pharmacotherapy. Adding CBT at the time of medication discontinuation actually reduces the likelihood of relapse. And adding CBT to medication continuation also led to lower relapse than continuation of antidepressants alone. There was no advantage to pharmacotherapy being continued versus pharmacotherapy being tapered, and the addition of pharmacotherapy may lead to an increased likelihood of recurrence. So the bottom line is including a maintenance phase in CBT lowers the risk of relapse, of depression in particular. In terms of predictors of outcome, for responders to CBT, a predictor of relapse is residual symptoms. So also no symptom improvement after about 5 to 9 sessions, so no early improvement, is also a predictor of later non-response. Higher severity of depression predicts worse outcome. However, this predictor isn't specific to CBT and appears to be a universal predictor of all types of treatment modalities. For example, baseline severity does not suggest that pharmacotherapy is a better choice than CBT. Now I'm going to talk about CBT for anxiety and related disorders. Like depression, CBT has been viewed historically as a first-line treatment for anxiety disorders. Compared to placebo, CBT for anxiety disorders had moderate effect sizes for acute treatment and long-term follow-up, with no difference between pill placebo and psychotherapy placebo. There were large effect sizes of CBT versus placebo for obsessive-compulsive disorder, generalized anxiety disorder, and acute stress disorder, and small to moderate effect sizes for post-traumatic stress disorder, social anxiety disorder, and panic disorder. CBT was also superior to treatment as usual. Not only does CBT have enduring effects, but studies show that it actually leads to additional gains following anxiety disorder treatment termination, lasting up to 2 years. In effectiveness studies, CBT also had large effect sizes compared to control groups for anxiety disorder-specific symptoms. CBT for one anxiety disorder has strong efficacy for comorbid anxiety and depressive disorders. Unified protocol interventions are not more helpful than CBT targeting one disorder, either on the main disorder or on comorbidity. There's also some evidence for superiority of CBT to other psychotherapies when delivered in the real world. Acute medication effects were not significantly different from CBT, but CBT was significantly better at follow-up. Combined medication plus CBT are not significantly better than CBT alone at long-term follow-up. In terms of specific techniques for anxiety disorders, in general, therapies containing exposure have larger effect sizes than therapies that don't contain exposure. and then primarily cognitive intervention packages, particularly for post-traumatic stress disorder, PTSD. The addition of cognitive restructuring didn't enhance the efficacy of exposure alone for anxiety treatment. So exposure is a very important technique to apply. Whereas progressive muscle relaxation alone was inferior to combined CBT, there wasn't any significant difference between combined progressive muscle relaxation plus applied relaxation compared to CBT, which suggests that therapists should always do both progressive and applied relaxation. Progressive muscle relaxation plus applied relaxation alone was not significantly less effective than combined CBT for panic disorder and generalized anxiety disorder. However, it was less effective than combined CBT for post-traumatic stress disorder, OCD, and phobias, for which in particular exposure is really important. In terms of prevention and predictors, CBT in those without current clinical disorders prevented the development of pathological anxiety, with gains maintained at follow-up. And individual CBT for anxiety disorders was better than group CBT, as well as group prevention interventions. So individual CBT, at least for anxiety disorders, seems to work better overall than group. Presence of comorbidity has been shown to predict greater change from anxiety than absence of comorbidity. So this is kind of the opposite of what people typically think. However, like depression, more severe anxiety predicts worse outcome. Although helpful, CBT for anxiety is not as effective for older adults compared to younger adults. And sudden gains during CBT predicted both short and longer term outcomes. In terms of mechanisms, reviews have concluded that both threat reappraisal and extinction of fear are the most likely mechanisms for anxiety disorder cognitive behavioral therapy. And in terms of effectiveness studies, benchmarking showed that effect sizes for real-world CBT were in the range of efficacy studies. And outcomes were best when therapists were trained, used treatment manuals, there was monitoring to ensure that therapists followed the manuals, and when there was not random assignment to treatments. Now I'm going to talk about CBT for personality disorders, and I'm not going to talk about dialectical behavior therapy because Evan is going to cover that. I, again, am going to focus on the first and the second waves. In terms of avoidant personality disorder, only a handful of studies have been done to examine the efficacy of CBT, but all of them have shown that it leads to significant change with large effect sizes, with gains maintained up to 1-year follow-up. One study also showed that 20 sessions of individual CBT was more efficacious than 20 sessions of dynamic therapy, but dynamic therapy was not significantly different from waitlist. Regarding obsessive-compulsive disorder, a small baseline controlled study found that CBT led to statistically and clinically significant change, with 90% no longer meeting criteria at post. If you compare 40 sessions of individual CBT to brief dynamic therapy for mixed cluster C personality disorders, there were no statistical differences in efficacy at either post-treatment or 2-year follow-up. Both treatments led to clinically significant change. And the treatments also did not differ in their impact on defensive functioning at post or 2-year follow-up, even though brief dynamic therapy was specifically meant to target those defenses. In terms of CBT for antisocial personality disorder, contingency management was better than group CBT, and both led to more cocaine abstinence than methadone maintenance at post-treatment using objective measures. At 52-week follow-up, more of those with antisocial personality disorder who received contingency management or CBT were abstinent than those who received methadone maintenance. Also, contingency management led to better treatment attendance and less psychosocial impairment than methadone maintenance. CBT plus treatment as usual for antisocial personality disorder was better than treatment as usual alone on problematic drinking and enhanced social functioning, reduction in reoffense and reconviction, improvement in impulsivity or aggression, withdrawal, anger, and social problem solving. In terms of CBT for borderline personality disorder, CBT plus treatment as usual was better than treatment as usual alone on number of suicidal acts, schemas, distress, and suicide attempts, with gains maintained up to 6-year follow-up. Individual CBT was also better than individual Rogerian therapy at retaining clients and had a 61% greater odds of success using all available outcome information. There was also no significant difference between CBT, group CBT and group dialectical behavior therapy on depression and suicide attempts. And behavior therapy was also better than insight-oriented therapy on suicidal ideation and behaviors and gaining full-time employment at the 6-month and 2-year follow-up. There are 2 other therapies that are straight CBTs that have been tested for borderline personality disorder. So one of them is called manual assisted cognitive therapy, which entails problem solving and cognitive therapy. And this treatment led to significant change in borderline symptoms and suicidal ideation. This treatment was also more efficacious than treatment as usual on depression, deliberate self-harm, positive future thinking, and suicidal behaviors, and was more cost-effective in several studies. The other treatment is called systems training for emotional predictability and problem solving, and this is a group-based skills treatment. And it was better than treatment as usual on borderline symptoms, objectively rated overall improvement, and self-rated improvement with gains maintained at 1-year follow-up, including fewer emergency room visits. Superior to treatment as usual for this treatment was replicated in a Dutch efficacy study, as well as an effectiveness sample at both post and 6-month follow-up. Another therapy for all kinds of personality disorders is schema therapy. And schema therapy was more efficacious, more cost-effective, and led to a greater percentage of borderline personality disorder recovery and better therapeutic alliance than transference-focused therapy. Group schema therapy led to improvements in unresponsive psychiatric patients with mixed personality disorders. Schema therapy was also superior to treatment as usual, and to clarification-oriented therapy on mixed personality disorders, with about 81.4% recovered after 3 years. CBT for agoraphobia plus schema therapy for personality disorders for inpatients also led to significantly more improvement than psychodynamic therapy on interpersonal problems and phobic anxiety at 1-year follow-up. Now I'm going to talk about CBT for psychosis, and this is something that has actually a large body of research. This treatment, CBT for psychosis plus treatment as usual, led to significantly more reduction in positive symptoms, negative symptoms, and overall symptoms compared to just treatment as usual. CBT for psychosis was also superior to supportive therapy on positive symptoms. And this treatment showed 14% lower attrition than other active psychosocial interventions. CBT for psychosis plus treatment as usual was also better than treatment as usual alone for patients who chose not to take psychosis medication on psychotic symptoms, with more therapy sessions leading to better outcome. Now I'm going to talk a little bit about eating disorders. And I'm going to start with bulimia nervosa and binge eating disorder. Overall, CBT significantly outperformed non-CBT at post, but only approached significance at follow-up. In another study that controlled for therapist allegiance effects, CBT was faster and more effective than psychoanalytic therapy, so less costly. But when CBT and psychoanalytic therapy controlled for therapist allegiance, specifically focused on eating behaviors, and both treatments lasted 2 years, there was no significant difference. CBT recovery rates are higher in binge eating disorder than bulimia nervosa. So bulimia nervosa is harder to treat. Two prevention programs, student bodies and cognitive dissonance therapy, have also shown promise for prevention of these two disorders. The most consistent predictor of outcome for these disorders was rapid response in the first few sessions. Also, change in dietary restraint is a common mechanism of treatment for both of these disorders. In terms of anorexia nervosa, this is a harder disorder to treat. And CBT for anorexia tends to be most successful if it's delivered as soon as the disorder emerges in adolescence. So for this age group, family-based therapy has shown efficacy over individual adolescent-focused therapy. Family-based therapy also led to fewer hospitalizations than adolescent-focused therapy and family systems therapy. For family-based therapy, early response was also a consistent predictor of outcome. For more long-standing adult anorexia, treatment response has been less efficacious than for adolescent anorexia. And for adult anorexia, CBT for eating disorders has shown some efficacy, but there isn't any evidence for its specificity compared to other treatments, including psychodynamic therapy. Okay, so I have 3 minutes left, and I'm going to try to wrap up. I'm not going to talk about substance abuse, but I'm happy to answer any questions about that. I'm going to talk a little bit about diversity in CBT and then wrap up. So What we know about diversity is that CBT tends to be effective for anxiety in both African Americans and Chinese people. However, meta-analyses have shown that white participants tend to fare better than non-white participants. And also, more recent meta-analyses have shown that culturally tailored interventions outperform non-culturally tailored interventions. Similarly, faith-adapted CBT for anxiety may outperform non-faith-adapted CBT for individuals who label themselves as religious. In terms of some transdiagnostic predictors, both quality and quantity of homework compliance predicted outcome at post-treatment and follow-up. Alliance and alliance rupture repair also predicted outcome from all types of psychotherapy, including CBT. Similarly, both goal consensus and collaboration also predicted outcome. In terms of where we go from here, we need more research that specifically tries to identify who are the responders and who are the non-responders and the best way to address them. We also need to do more work to understand the mechanisms of change in CBT. Future research comparing two active therapies needs to do a better job of discriminating the unique features of each therapy and ensuring there isn't bleeding across the two treatments. Also, studies need to be powered to find small effect size differences. And since a big issue in CBT is dissemination, we need to continue to explore conditions under which the use of paraprofessionals and self-help or low-intensity interventions are helpful. Thank you.
Excellent, Michelle. Many thanks. I clap here, and I think we'll just directly switch to Evan, and then, or is there any technical questions, details at this point? So we have an overall discussion at the end. Evan, just go ahead.
Sure, okay. Well, hi, everyone. I think what I'm going to talk about, the so-called third wave or mindfulness and acceptance-based treatments, has a lot smaller evidence base and a lot less nuance in the evidence base. So in certain ways, there's sort of a repetitive pattern that you'll see that in terms of what I can present and synthesize in the literature, and many questions left. But still, there is maybe a clear pattern, and I can try to describe that. So let me start my slides here. So just to clarify, third wave is a term some people use, some people don't like it, but it's a synonym of sorts to the idea of acceptance-based or mindfulness-based approaches. And because a lot of these treatments utilize multiple components that are similar or some way related to mindfulness and acceptance-based treatments, we're just using that as a universal term for this umbrella of treatments. So the idea is that they blend Western cognitive behavioral approaches, for the most part, with Eastern mindfulness concepts, such as psychological awareness, meaning like awareness of the present moment, being in touch with the present moment, being able to name and describe one's internal experiences, thoughts, feeling, urges, sensations, and so on, with some concept of not judging those internal experiences, of psychologically accepting them, of being okay with them, however they may be, whatever form they may appear in. And the idea is that lets you have a more flexible behavioral repertoire of what you can choose, and you have the power to choose behavior, just whatever is going on internally. That's the idea. And there's a de-emphasis on altering internal experience, which in some ways differs from the more traditional cognitive behavioral approaches. So there's a de-emphasis on reducing symptoms or of changing or modifying thoughts and so on. And there are many prominent psychologists and other scientists who have developed these treatments, and they don't necessarily all have the same exact views, but these treatments are often stemming from the work of these more prominent voices like Steve Hayes, Marsha Linehan, and so on. One thing to emphasize here is that despite some distinctions between everything that Michelle was talking about, all those treatments and the so-called third waves, it's more that maybe the differences in what they're emphasizing and in the perceived utility of these different aspects of psychotherapy, not that they're completely different. There's a lot of overlap. But for example, the reduction of symptoms is considered, high priority or an emphasis in second wave, not so much in the third wave. Altering those cognitions similarly seems to have a distinction. But awareness of experience seems like it would be present in both. The psychological acceptance may be another area of bigger distinction. On the other hand, achieving some kind of metacognitive distance, decentering, diffusion, whatever words you want to give to that, seems like something that's overlapping and something maybe we'll come back to at the end in terms of like what is really driving these effects. The identification of and living in terms of values is something that tends to come up in third wave more so than second wave, but perhaps it's just more of a distinction of terminology in part, because obviously more traditional treatments always talk about treatment goals, which are, you would assume, are inspired by values, but it's not as explicit, the values work. Okay, so I'm going to advance. So just to go on here, there's the idea that there are these different sub-treatment categories of MABTs: acceptance commitment therapy, ACT, MBCT, mindfulness-based cognitive therapy, DBT, Michelle had mentioned, and acceptance-based treatment, which we're calling ABT. Those are the ones that seem to come up the most often in terms of these different categories. And then I would say that these are the individual and specific treatments that that we found to review, essentially, that there's enough work on these specific treatments for these specific problem areas that they could be reviewed. So that's what I'll just try to synthesize. And I'm going to try to do that pretty quickly because, like I said, there's a fairly repetitive pattern here and maybe a little bit less nuance to talk about. So ABT for anxiety disorders, I'm sure you've heard of mindfulness-based stress reduction. That was sort of the progenitor of a lot of these, but actually there's not that much data, whereas the ACT-based treatments have generated a lot of empirical evidence. They're the ones that are focusing on the psychological awareness of thoughts and feelings, urges, sensations, and especially the willingness to experience them and the flexibility to choose behaviors that are in line with one's goals or values. It does raise a question, which I'm pretty much going to ignore for the whole presentation, which is like, what should the outcome variable be? How do you assess a therapy that's not supposed to reduce symptoms? So mostly we won't talk about that because just in some ways to review meta-analyses and such, you're pretty much stuck with the usual cast of characters. So there is a pretty good evidence base for anxiety disorders. There's at least 15, reasonably rigorous randomized controlled trials. There's been at least 4 meta-analyses, and they show that these ACT-based treatments are highly effective across, which I'll say in a second, across multiple anxiety disorders, and that it seems as if the efficacy is equivalent to the treatments that also show the best efficacy. That seems to be the consensus across these meta-analyses. So you can see that show up whether you're looking at RCTs of heterogeneous anxiety disorders, such as these that I'm just flashing on the screen. You see that show up in terms of generalized anxiety disorders. You see it in terms of social anxiety disorder, and panic disorder, there's less evidence for, but even there's at least one RCT that seems to show these ACT-based treatments are effective. With OCD, we have more to go on. It seems like it's standing up pretty well. And well, I guess I would say that's essentially if we're talking about anxiety, that's the consensus seems to be that these ACT-based treatments do a very good job of treating people who have anxiety disorders. And presumably, as from what we can tell, as good a job as other treatments pretty much every other treatment that we have been evaluated. In terms of depression, mindfulness-based cognitive therapy by far has the most evaluation of it. It is showing, it is intended to prevent relapses of depression in the sense of major depressive episodes being episodic, cyclical. The idea behind it is that we are going to help our patients develop metacognitive skills to disengage from depressogenic thoughts, to step back and see those thoughts as not the same thing as the self or as truth, and to be able to look at those thoughts from a distance and to be aware in the moment of one's thinking and the patterns of one thinking, and that thoughts are just as they are, thoughts. And we see that there's a pretty good evidence base now. There are meta-analyses that seems to show that in fact, MBCT can prevent depressive episodes and can do so at least as well as other treatments. And that's true even across long periods of time. So again, we see good evidence for this particular treatment in terms of major depressive episodes, the prevention of those episodes. There are, just like Michelle was talking about, there are some specific treatments that have been developed for psychosis. In this case, we reviewed ACT for psychosis, ACT-P, sometimes it's called. Here, you're helping people to accept their psychotic experiences, meaning that they're not trying to fight against them. They're sort of aware that something in their brain is creating these experiences, such as delusions. And being able to do that while still pursuing personal goals, personal values is the objective of the therapy. So you help someone develop the flexibility to pursue valued action, despite whatever delusions or hallucinations, et cetera, are occurring. And the same is true for negative symptoms as well. Here, there's not as good of an evidence base, but what we have seems to show that it does, in fact, reduce both positive and maybe negative psychotic symptoms. It does, in fact, reduce depression, and it improves functioning. And maybe most importantly, it's been shown pretty, I would say, convincingly to reduce rehospitalization rate, which, a very concrete metric. Okay, well, Michelle previewed that I would talk about dialectical behavior treatment. So here, I guess one thing to emphasize here is that DBT is multi-component treatment. It is individual therapy, and that's important, of course, but there's a skills training component and usually a skills training group. There's inter-session phone coaching that's considered essential in DBT. And then there's a therapist consultation team as well. And the focus is on developing emotion regulation skills and interpersonal effectiveness skills. So there have been quite a few, I didn't realize there have been so many, but there have been quite a few randomized controlled trials conducted on DBT, and there have been some meta-analyses as well. Here, this may be one, I'm not sure what you think, but I thought this might be one deviation from the pattern in that, at least as publicized, DBT is almost viewed as our savior. Like it's treating borderline personality disorder and suicidality because no other treatment can, in fact, address these problems. So I was sort of under the impression that the body of evidence would show that DBT is far more effective than any other treatment, but that didn't really seem to be the case. It seemed to be on par, even with treatments that were far less comprehensive. It still seemed to do similarly. Not that it doesn't, not that it's not effective, but I just had the impression that it was. I think it has a very like maybe the marketing is outpacing the evidence or something like that. But that was interesting to me. The other part of this, there's not too many instances I can point to in this literature where there were component analyses, just a few, and that's something I'll try to come back to at the end. But that there was some question from some of the component analyses whether all those multi-components that I talked about a minute ago actually are needed. Some studies seem to show that even if you leave out the skills component, people do close to as well. There's some other studies, which I don't say here, where they only gave people skills training and there was no therapy at all. It was just like skills training, and people did well in those too. So I think these component analyses always raise interesting questions about what do we even need to be doing? And it might not be what we think. Eating disorders has a collection of mindfulness and acceptance-based treatments, it turns out a lot of people get MABTs for eating disorders. A lot of people who have eating disorders, it seems to be one of the more popular treatments, something I didn't know either until this review. The treatments they do vary somewhat in terms of what is delivered, but some combination of emphasizing mindful awareness, distress tolerance, emotion modulation, the values-based decision-making I had mentioned, and then usually some behavioral skills or specific recommendations, such as making eating more regular, reducing dietary restriction. So in terms of the evidence base, it's not as good as most of those other clusters that I showed, but there are a number of studies. It's just that they tend to be confusing packages. A lot of them are small, controlled, open trials. The comparisons are often not gold standard, and then a lot of times the individual studies are underpowered. But there is a meta-analysis that reviewed almost all of these studies, and generally speaking, it seems like these treatments do in fact bring about large improvements in primary outcomes and also in secondary outcomes. And then it does, at the least, does better than waitlist controls, and it seems to do as well as other treatments that have a lot of evidence behind them. Okay, so moving on now to more behavioral medicine considerations. It's interesting unto itself, maybe, that these treatments have in fact ported over, to like the non-emotional side of psychological interventions. So I was going to talk about smoking, weight control, and pain as well, chronic pain. So for smoking, there's a treatment act for smoking. The idea here is that you could learn to accept, be okay with, welcome, invite, etc. Intense physical cravings, which you would have when you're trying not to smoke. Emotions that might cue smoking, thoughts that might cue smoking, or even just give yourself permission. And the idea is that you can let these experiences come and go. You're not trying to control them. You're in a position of acceptance, and you are teaching people to marry that with the idea of commitment, meaning because you can accept those internal experiences, you can choose to stop smoking because that's in line with your values in life. So that's the idea behind the treatment. And just quickly, it's worth saying that if you don't have treatment for smoking, you're very unlikely to be able to quit. Only about 4% of people who try on their own are successful at quitting. If you use the gold standard, the US clinical practice guidelines, you have about somewhere between a 6 and 25% chance of quitting. And that has multi-components, everything from pharmacotherapy, motivational interviewing, identifying quit dates, etc. So a lot of trials have compared ACT for smoking to these clinical practice guidelines, and they seem to show that it at least does as well, but in most cases seems to do better. So, for example, in this one was a web-based, but there were some coaching as well. We see that the ACT-based treatment got a 24% quit rate as opposed to 9% in the control, the US CPG control. Similarly, not quite as stark, but in the SMART-based, we see that. In a phone-based treatment, we seem to see that. So it's looking like the ACT-based treatment actually does very well, even compared to, I would say, a pretty good control. So I mentioned weight control. Just quick background here. I think it's just worth saying that if you looked at the US, for example, we're now at a point where 42% of people would fall into the category of obesity, quote unquote. It's a controversial concept even, but just by BMI, medical BMI, and 70% of people would be classified as overweight. And that's probably why at least half the population is essentially attempting to lose weight at any given time. And even more people are just trying to control their weight to keep themselves from gaining weight. So it is affecting a huge numbers of people, and people who these 100 million people or so in a country and many hundreds of millions more throughout the world essentially do not achieve success when they try to do this on their own. But there is a gold standard, behavioral treatment that does decently well. And a good example of it is the diabetes prevention program. This intensive modification, you usually have 20, 25, 30 sessions over a year. People can gain lose a substantial amount of weight. So the question always becomes, of course, you can teach people what to change about their dietary intake, about their exercise habits. It's very hard to get people to do it. And that's probably because biologically we're pre-programmed to, enjoy certain foods and eat in certain ways. And our environment is full of all sorts of temptations, and there's no need to, be all that active. And so it actually turns out to be pretty hard to get people to make and sustain these changes. So that's why these treatments seem to be necessary. So just quickly, ABT for obesity, it's trying to infuse these behavioral techniques with the MABT strategies, again, emphasizing the psychological acceptance of cravings, urges, the loss of pleasure, boredom, permission-giving thoughts, and so on. The concept of willingness is a really important idea that because of this acceptance, you're able to choose behaviors that are in line with your values. Of course, you have to figure out what those values are. Maybe it's you care a lot about your grandchildren and you want to spend time with them, and that has certain implications for how healthy you're going to be at different stages in your life and how mobile and so on. So you connect that with the individual behaviors. So I'll just go on to say that there's several very large trials, but there's a little bit confusing to make sense of, only because different treatments use different components inside. But for the most part, it seems like acceptance-based treatment is effective, and probably even more effective than the gold standard. It just might depend on which components are there or not there. And an example, maybe there's just not enough research on this, but there's a very popular version of mindfulness-based treatments for weight control called mindful eating, or sometimes people call it intuitive eating, appetite awareness. It seems like that doesn't actually produce weight loss, but it's actually the most popular in the lay public and in general. But it may be that's actually the least effective component, just to give an example. Okay, well, I'm going to start wrapping up by first I'll talk about the very last part of the synthesis, was to look at ACT for chronic pain. Here we're talking about the ability to figure out what in life has meaning for you as a person, developing willingness to experience pain in the service of pursuing what matters to you. That's essentially what the treatment is. And again, we have a fairly good evidence base, maybe a surprising amount of evidence base in terms of many randomized controlled trials, several meta-analyses, and they show substantial effects. And these treatments seem to be sustained even into the follow-up. So for that reason, it got to earn the strongest version of empirical support according to the APA Division 12 criteria. And overall, it seems like it's a highly effective treatment. So that brings me to the conclusion. Just a few points there. One is it is, as Michelle mentioned, of special interest to try to identify what drove the effects of all these treatments. And I'm not saying this slide answers that at all. I'm just saying that there's a lot of theory about what's supposed to be driving the effects, and there's a medium amount of evidence maybe about what is driving them. And there's some ways in which these two line up, which kind of support some of the theory. But I'm not convinced personally. And I guess the reason I say that is because, first of all, almost all this evidence comes from self-report measures. And I don't think we should rely on those particularly well. If you think about, if you spend a lot of time convincing people about what the treatment is and what it's doing, and then you ask them questions on a traditional self-report measure, of course they're going to endorse certain changes, and those will correspond with symptoms. We don't even know what's cause and effect. There's a huge file drawer problem in our field, I think, where when mediation effects don't work out, we just don't publish them. We don't include them in our papers. There's also the problem that, I don't know if it's a problem, but it's an interesting problem, I guess, which is that often you find evidence of mediation of mindfulness and acceptance-based mechanisms of action are also seemingly active in non-MABT treatments. So like we've found that many times, so have others, meaning that what does it mean? I mean, that's the question. Maybe these are in common, and that's something we could talk about maybe afterwards. I think what we need is dismantling studies or component analyses in part to answer some of these questions, and maybe some other things as well. So we do, in conclusion, I think, have a large evidence base that, on the whole, in terms of mindfulness and acceptance-based treatments, they do seem to be, I think you could say they're highly effective, and that's true. I didn't say this, but in a few cases, we know that's true even for people who didn't respond to other treatments. So that's interesting. That maybe you could either think of it as first line or maybe second line in terms of the treatment. The effectiveness, generally speaking, is on par with other treatments. Maybe you could argue that MBCT is even better at preventing preventing relapse, or ABT was even better than our gold standard. And then seems to be true across many areas: mood, anxiety, behavioral medicine. So there's a lot of conclusions that we could draw from that, but I think that one thing we maybe can't be so sure of is what are the mechanisms of action. Again, they're well supported in our conventional sense of self-report measures, kind of correlate with outcomes or predict outcomes, but I think we do need component analyses to really figure this out. And that may even give us insight into how MATs exert their effects. So, to name one construct, metacognitive awareness, this idea of being aware of how our own minds are working. It seems to be a mechanism of action that could span many different kinds of treatments. It seems interesting to me. And then there are many other kinds of future directions, everything from understanding, which kind of people should get MABTs versus other treatments. And even some people are going in the direction of process-based therapies. Like I think Steve Hayes and Stefan Hoffman have talked about the need to develop therapies that can identify that they're no longer anything to do with first, second, or third wave or any other treatment, but somehow identify which processes actually drive outcomes, and making therapies where we can draw from all of those. Maybe that's the future of psychotherapy research. I'm not saying it is, but it's certainly been argued that it is. Okay, well, looks like I'll wrap up right there, and we can move to our next phase.
Thank you very much, Evan, and thank you very much again, Michelle. I clap here shortly. You can also show this with the signs in the Zoom. I think it is an example of really excellent webinar with two experts and the expert chapters and expert presentations. And I really like both of your presentations. I also like that phrase from Evan, which is in some way somehow representative for our handbook in a way, is how did you say it, that the marketing is not outpacing the evidence for some of the concepts. And I really liked in that way how detailed you framed the results, and you explained the results, and you also discussed the lack of knowledge about mechanisms and mediators of change. I would like to open up now the discussion. Who has questions? We still have nice time to discuss. Denise?
Hello, everybody. Thank you very much. Wonderful presentations. And I think we need this sort of brush up on new trends. But I would like to ask both of you about exposure, because this is not usual in our countries, and I'm sort of terrified, because I always sort of hear it as a description, but I like to hear about negative effects, because I'm terrified, because wild psychotherapy is becoming widespread all over. Anybody does anything. And this is one of the most tempting techniques, say, calm and constellations and this kind of things, biodecodification, which tends to be widespread, done by anybody, So I would like to hear on evidence about negative effects of exposure.
So I can say that for the most part, there are a lot of things that go into doing exposure therapy with clients. And I think that a lot of it also depends on a lot of things the therapist does and tells the client about the exposure. So, for example, in post-traumatic stress disorder, we know that exposure initially makes the client worse, and they're going to experience more PTSD symptoms. It's going to feel more uncontrollable. They might experience a lot more somatic symptoms. And the way that at least I always recommend therapists do exposure with PTSD clients is to tell them this up front. What's the goal of exposure? The goal is for them to experience and process their emotions in that case. And so it will get worse before it gets better. And sometimes clients then say, you know, I'm not ready for this. And other times clients are like, what we know, it's incredibly effective. So in the short run, if you want to talk about negative effects, we know that the goal of exposure, though, isn't to make the anxiety go down or the negative emotions go down. It really is for clients to experience their emotions and develop distress tolerance in a lot of circumstances. So a big part, like I said, of exposure is being clear to clients about what they're doing and what the goals are. And I will say the other thing is that when therapists are afraid that the exposure is going to do harm, they in their meta behavior, they communicate that to their clients in ways that the clients immediately think, oh no, this is a bad thing. And then the therapist backs down and the client backs down. So a big important part is actually how you do it and how you introduce it. And you need to introduce it with positivity and no trepidation. And you need to be okay with your clients being uncomfortable. If you're doing exposure with them, that's the goal. But
what about, excuse me, what about attrition? Attrition. They go when they go after they've been.
Yeah, again, in my own experience, you know, once you explain to clients both the goal of the exposure, the process, what is expected, what they're going to do, what it's, you know, that for example, their anxiety is going to go up. They need to stay in the situation despite their anxiety until their anxiety starts going down before they stop, before they escape. There are lots of very specific nuances. And again, you introduce everything. In my experience, we don't have that much attrition. You know, clients, if you do it correctly, and I have this because I train a lot of new therapists, it's incredibly efficacious. And both the therapists and the clients are like so happy, you know, because ultimately it goes well, but you have to be clear up front, again, what the process is going to be, what the goals are. And similarly, like in social anxiety, the goal isn't to avoid doing something that's going to embarrass you. Or the goal isn't to, you know, make everybody like you. And So a big piece of it, like I said, and the goal isn't, if you ask somebody for a date to get the date, like that's not the goal. The goal is to feel good that you put yourself in this uncomfortable situation and you tolerated it.
Yeah, I would agree 100% with everything. And in fact, I think I would argue that of course there could be some rare cases where exposure led to led someone to drop out of treatment. Like that of course is like theoretically possible, but I would say that that's much smaller problem than the one that you were just talking about, Michelle, which is that we're not doing enough exposure. And that so one of the ways we've conceptualized this in some of our earlier work was that not only are the patients themselves having a difficult time accepting or tolerating their own anxiety or distress, but so are the clinicians, which you alluded to. And that we've even done some studies to show that the level of distress tolerance in therapists is correlated with whether or not they do exposure at times when they really ought to be doing it. And that's the bigger problem. And that if you can teach clinicians to be able to be okay with these very difficult experiences, they actually do a better job of conducting, facilitating exposures. So to me, that's how I think of it. And I also think it's an interesting example of where maybe the supposed second and third waves come together. And just like you said, you're trying to help people. Actually, even first waves, like whether you're talking about just, okay, go do these behaviors, or whether you're trying to change people's cognition so that they can do these exposures, or whether you're talking about distress tolerance so that they can do the exposures, maybe like what's ultimately happening, changing psychologically, is actually the same in all three cases. We may think it's different as clinicians, but maybe what's actually changing in somebody's mindset or brain is actually the same.
Manula?
Yeah.
Hope I pronounce it correct, yeah?
Yes. Hello, everyone. I would like to add on to what both Michelle and Ivan was talking about. I think in my clinical experience, exposure, like if it is done properly, and if the therapist explains the rationale for the exposure, and it is done graded in a graded manner, graded exposure, and if the client is prepared well, and if the exposure is done properly, in the sense that the duration of the exposure and the frequency of the exposure sessions, and sometimes like we have to do it in the session first, and then maybe like the therapist helps, and then you can take it forward. So I think those are the things which will make sure that the exposure works, instead of exposing the client to a high intensity anxiety levels. So I think that also matters. And of course, the therapeutic alliance in the beginning, and how much you prepare, how much psychoeducation is required, how much preparation is required for them to start the exposure. So these also plays an important role. Thank you.
Louis?
Yes, my comment is very similar to what you just mentioned, Majula, as well as the comment that John is posting there. But I want to put it in the context to address what Denise was mentioning, which is that, there's a lot of people that are being now using CBT and exposure. And I think, in part the part of the problem that you're raising there, Denise, or your fear, is due to the fact that I think that there's a tremendous number of people, in my view, who are practicing CBT, may not have received an extensive training of it, and or have been mostly trained just by using treatment manuals that have been published, and or attending one or two workshops. It would be, I think you would agree with this, Denise, that it would be absolutely unethical, feel as mostly unethical by most psychodynamic therapists, to say the only thing that you have to do is to go to one conference and sit down to a 2 hours workshop and now say to yourself, I'm a psychodynamic therapist. The problem, a lot of CBT therapists who define themselves as CBT therapists just went to MBCT, took a seminar, bought a few texts, bought a few treatment manual, and never read neither the major classic that led to this treatment and or the basic research in line with what John was saying in terms of reinforcing, advancing avoidance behavior. So I think it is really important to consider that these treatments are not only based on very solid evidence, they're based on very logical principles of change. These are laws of change. Avoidance, negative reinforcements are laws of change. And it's the problem is that a lot of people are not fully trained in basic literature, as well an extensive systematic treatment of CBT, which in my view is as complicated and as difficult to do than psychodynamic treatment or humanistic form of therapy. But there's a double standard in how we feel that people can actually be using them. And I think that's one of the major problems of why people are so afraid of exposure, because they don't really understand the conceptual and law that are based on.
And I'll just add, because I completely agree with that, Louis knows, that the therapist really needs to understand those principles of change and be able to explain them to the client, because the idea is that you want the client to change their behavior, not just in the session, but outside of the session. And they need to understand why they're doing what they're doing and how it functions. So a really detailed rationale, for example, based on like classical conditioning in the case of like exposure is critical, and understanding the fact that when you avoid something, you actually negatively reinforce your fear of that thing, and the strength of that fear increases. So the more you avoid, the worse, because the other thing is consistency is really important. It's not just they do the exposure once and then they go off and keep avoiding in their real life. Once they've exposed themselves to something, they need to maintain it. So those are two other things. And, all of these are solidly based on learning principles.
I have another question. It comes a little bit from a different angle, and is more related to the conceptual background of the different theoretical developments within CBT and the so-called third wave, or whatever name we want to use. What I think, or what I observe, is that in many programs, in many CBT programs around the world, that now more and more also third wave concepts are finding their place and are taught. And I was wondering, and sometimes I can see this when we do exams from students, when they present their cases, that they have problems to bring the case conceptualizations together because of the different theoretical backgrounds of the different theoretical traditions. And I was just wondering your thoughts on this, and how this might develop further. I mean, given that we not having so much knowledge or on mediators and processes of change and well-studied processes, but how you perceive this and how you handle this. So it's actually a question to you both. Yeah.
So I actually think there are more commonalities than differences. For example, Evan and I have talked about this because historically, the sort of this notion of present moment focus, being in the moment, is very, very key to applied relaxation, for example. And so there's a lot of connection between mindfulness and actual, noticing your emotions. I mean, the difference is a little bit different about what you do, but it's not that different. And so I could see easily, I guess I don't see this as, a dilemma. I think a lot in conceptualizations, we think about the different things that are functioning in the client's life. And I think a lot of the same components would apply.
Yeah, I agree. So I fully agree with what you were saying. It was also just making me think about that other dimension that you brought up related to the trainees, essentially the training of therapists. And I started thinking about how there's maybe a tension between wanting our next generation or current generation of therapists to fully understand all of these complexities, to really, like we were saying, to understand the learning principles behind the treatments, to be able to explain them well, implement them with the right positive frame of mind and so on the one hand. And on the other hand, if it's too complicated, it sort of limits who can actually deploy these treatments. And so I'm not saying I know the answer, but I would say that if you look at the entire universe of clinicians that we have, probably we're not doing a good job of educating them to be able to understand and utilize effective treatments. I would say, like, if you're a patient and you just go to a random clinician, you probably won't get very good treatment. I think that's the sad state of the affairs in the world right now. So somehow we have to balance educating people about these fundamental principles and how to utilize them, how to distill from them effective therapeutic techniques, whereas not making it so complicated that most therapists will never be able to do it, which I think is what's happening right now. So maybe Michelle knows how to do that, but I feel like that's a dilemma or tension that we have in the training field.
Excellent. Interesting. Many thanks. I think we are coming to the 75 minutes, but is there one more question? I don't see anything in the chat. I think it's MBCT, not MCBT. Can you look at this, Evan and Michelle? I'm not sure what.
Yeah, I think that he's talking about metacognitive behavior. I think he's just coining a new term.
Okay, good. So thank you very much, both. And yes, have all wonderful holiday season, and see you all in the next year latest on the 21st of February. So bye now. Thank you again, Michelle and Evan. Thanks for wonderful presentations.
Bye, everyone.
Bye.
Bye.
Thank you.
Many thanks, Michelle and Evan. Many thanks. Brilliant.
Thank you. There's nothing more we're going to talk about, right? We should just sign off.
Yeah, you can just chill.
Yeah.
Don't have a pint.
All right, well, great seeing all of you. Thanks for inviting me.
Yes.
Wonderful. Of course.
It's wonderful.
Thanks.
Well done.
Thanks.
Bye, Michelle.
Bye.